Thank you everyone for joining us in our CPD talk. Please be reminded to put in your HPCSA registration number in the chat right now and closer to the end of our presentation today, that is for the CPD points allocation. Today I have the pleasure of introducing our speaker, Dr. Kyle Dunkle. Their pronouns, they, them. They're a queer social epidemiologist who has been working on preventing and responding to sexual and gender-based violence and health in South Africa for over 20 years. They are a chief specialist scientist in gender and health research unit at the South African Medical Research Council and also work as a private consultant. They are currently a partner with the US Center for Disease Control and Prevention and target districts in Department of Health on improving care for survivors of sexual and gender-based violence through developing a quality assurance tools for clinics. They have a particular interest in improving post-GBV services for LGBTIQ+ survivors and those with disabilities, and are currently co-developing trainings for healthcare providers on these topics.
Dr. With Dr. Stakiwe and Ms. Swelly.
Yes, you've published widely and have connections in areas of intimate partner violence and HIV amongst both women and men, and looking at links based on gender-based violence and transitional sex and poverty, prevention of intimate partner violence across multiple countries. To name a few: Swaziland, Rwanda, Zambia, India, and China, and America, which is your home country. Funny little fact.
Don't tell people that.
You like dogs. And I believe that. I have experienced it. So I'm looking forward to your talk. We are ready to feast. Thank you so much for taking your time from your busy schedule to share with us your knowledges this evening.
Thank you for the incredibly warm introduction. Anybody who feels like keeping a camera on so that I can see who I'm talking at, that would be wonderful, but no obligation. I do understand that sometimes one just wants to listen and get on with one's life. And now we get to see if the slides are going to advance the way they're supposed to when I do this. Okay, so I just want to start, as I often do with this topic, and I think it's important, with a content note. You all showed up tonight knowing the title of the talk, so you know that we're going to talk about violence, but do have a care for your own selves. This is something that touches nearly everyone in South Africa and nearly everyone in queer community, whether directly or through friends. So if you need to step away, I promise I won't be offended. This is definitely a topic where, if you want to provide good care for others, it's important to follow that emergency medical doctor's rule of always check your own pulse first and make sure that you're okay and that you have your own supports in place before you engage. So I don't want to belabor a topic where a lot of people, I think, already have quite good knowledge, but I thought we could develop for this topic, when talking about trans and gender diverse people, a shared definition of gender-based violence. And this is sort of adapted from standardized USAID, WHO, and a range of other definitions. So gender-based violence is then any form of violence against an individual that's based on or driven by their biological sex, their gender identity or gender expression, or their perceived adherence or lack of adherence to socially defined expectations about what it means to live in our cis heterosexist world. It obviously includes sexual assault, intimate partner violence, can also include child sexual abuse, physical or psychological abuse, threats, coercion. This arbitrary deprivation of liberty is a very standard phrase, but it does tend to really refer to controlling people's movements, and economic deprivation, where you're meant to be in the role of a provider. So I think the important thing to understand is that this is a phenomenon rooted in gender-related power differences that include the social, economic, and political inequalities, and then is characterized by the use and abuse of physical, sexual, emotional, or financial power and control. I have long been a big advocate, and I think for this group, I won't have to sell it at all, that this really needs to be an expanded definition that includes both individual level and institutional and broader levels of attempts to enforce sort of cis heterosexist gender binary norms on people, as well as dynamics within individual relationships. And we can talk more about that as we go on. So sexual violence then is simply using forced or coercion to make another person engage in a sexual act that they don't want to, or to attempt to do that, or basically any other act that is directed against a person's sexuality or sexual self-expression by anybody, regardless of their relationship to the victim. So most often in South Africa, we talk about rape, and most often that defaults to talking about a male perpetrator, a female victim, and penile vaginal acts. Obviously, we want to expand and think more broadly about this definition, and in particular, if we're interacting with clients, we want to support clients to validate and name their experiences, regardless of whether they fit that sort of commonly acknowledged act that we tend to call rape, but is not the only thing that can be rape. Intimate partner violence is the other form of SGBV that I really want to focus in on today. And so that is ongoing or past violence or abuse by a current or former partner, any kind of partner. And it includes physical, sexual, emotional, economic, and controlling behaviors. I think it's important to recognize that, particularly when it comes to emotional abuse and forms of control, that there are ways that this shows up in queer and trans relationships that can be very specific to those kinds of relationships. So that mocking somebody's sexuality, telling them that they're not a real whatever they identify as because they're not a gold star lesbian, or they happen to be bisexual, and you're enforcing a sort of monosexuality standard. With trans and gender diverse people, this can show up in terms of all kinds of abuses and humiliations around someone's body, the way that they inhabit their body, what kinds of gender affirming care they have or haven't been able to access. And then, of course, threatening to out people to their family, to their workplace, or others in ways that are vulnerable. And this is something that's sensitive within the queer community, because obviously threatening to out people in a way that would make them unsafe is cruel and unkind and abusive. But there can also be complicated dynamics when in a relationship, when one partner drags another partner into a deep closet with them, which then compromises that person's self-expression. And that's something that we could talk about if people want to get into that debate. So if my slides will advance. I noticed as we were beginning to talk about this, that we do have a lot of folks on the call who are focused on providing mental health care. So I thought it would be helpful then if we start about talking about some of the clinical needs. If you have an acute case of sexual and gender-based violence, and you have a patient who is presenting to you, or even a friend or a colleague, I have certainly had to support professional colleagues through these kinds of events. What are the acute needs if somebody shows up in the immediate aftermath of an event for clinical care? And what are the things that you want to be prepared to talk them through? And as I go through here, I'll be referencing the work that a couple of you know about, which is in our partnership with CDC. We have been working with some of the Department of Health Clinical Forensic Medical Services and with the TCCs, the Tutuzela Care Centers, which are the one-stop services for sexual and gender-based violence in South Africa, that are a collaborative effort between Department of Health, Department of Social Development, and National Prosecuting Authority, and who takes point and what amount of leadership each agency has does tend to vary by province. And doing some work around, so that's where this quality assurance project has come in. So I'll make some references to those public services as we go along. So, sorry, the advancing of the slides are just going to be a little bit fiddly, and we'll all be patient about that together. So, if there is a patient presenting to any facility with an acute case of sexual or gender-based violence, this person has just been raped, they've just been assaulted, regardless of their gender or sexuality, they have some particular health needs. The first need, obviously, is to ensure that the patient is stabilized and to treat any major injuries. This step is often not necessary because the person does not need the services of casualty. But if they do need to be stabilized, that has to take priority over everything else. But the important thing to remember with all of this care is that if you're working with a patient who has experienced violence, they've just either in the immediate past or in the more distant past had an experience of being completely violated, having all of their power and control of the situation taken away from them. So the thing that is most necessary through all of these clinical encounters is to do as much as is possible to restore that person's sense of agency and to help them feel in control of the clinical encounter, even if that means they're making decisions that you would not make for yourself or that you don't necessarily agree with. There's a handful of time-sensitive things that need to happen, and we're going to talk about that. But really, the most important thing that you can do for this patient or client or friend or colleague or whoever you're supporting is to respect their agency and return to them a sense of being in control. Now, this is difficult when somebody has showed up at casualty and they have severe injuries. So to the extent possible, if the patient is conscious and able to interact, you want to involve them in their care and treatment decisions. You want to make sure that you're explaining to them what's going on, that you're using appropriate language to talk about them and their relationship and not making assumptions. Now, not a lot of casualty doctors in this country are going to be trained in that. So with a TGD patient, it will be ideal, if possible, to allow them to have a support person who can help advocate and run interference. But obviously, if it's a medical emergency, it's a medical emergency. And the most important thing is to make sure that the patient is actually given the necessary care. After that, this will be in many cases, the patient is now stable or the patient has presented at a TCC or they've presented to you as a mental health care provider. If it's within the first sort of 72 hours to 7 days after the event, there are a range of things that you do want to think about in terms of acute medical interventions. If it's an immediate event, you want to take a detailed history of what has happened, and then together with the patient, make as good a decision as possible about whether or not they want to have a police report made, whether or not you're going to fill out a J88, which is the official medical legal form in South Africa. I trust most folks know that, but I don't want to make assumptions, and whether or not they want to undergo a clinical forensic exam. Now, this is a time-sensitive decision if you have an acute case. So there's a lot of evidence that starts to degrade, and if the assailant has ejaculated inside of the victim, if there's any DNA evidence to be retrieved. All of this is time sensitive, but the time sensitivity should never override getting informed consent and helping the patient to make a decision that they feel really solid about. So what you want to do here is to really explain to the person what's going to be involved in these forensic exam procedures. I'll speak a little bit about this in a moment. Chris is on the call, who knows this also very well. And you want to explain to them what are the likely outcomes and the possible outcomes of either decision. And in particular, you're collecting this forensic evidence can help ensure a successful prosecution. But even cis heterosexual women in this country very rarely get a successful prosecution. And you're looking at entering yourself into a system that is not designed overall to support TGD people, that is likely to cause them to encounter a lot of suspicion, a lot of queerphobia, a lot of transphobia. And so there's this balance to be struck between being very clear about you need to do this in order to make a prosecution possible, give it a chance of success. If that happens to happen, these are the possible outcomes. Even if you want to preserve the option of doing this, preserving this evidence is a good idea. At the same time, be aware that entering into this process can be incredibly re-traumatizing. And of course, it's a time-sensitive decision, so you don't have a lot of time to work it through. Some CFMSs or TCCs will offer the opportunity to collect the physical evidence and to wait on a final decision about filing a police report. Others will give you a lot of attitude about just how much money that rape kit costs, or they can't get the police to actually provide them with a rape kit because they don't have them on site. And so to get a rape kit, the police have to be called. The police must now bring the rape kit, and the police won't hand over the rape kit unless you're making a police report. So it's important to be aware of those dynamics when you're talking through with a patient whether or not they want to make a report and do this. So if we are doing a forensic exam or completing a J88 form, this can be done by a range of medical providers. In practice, if you want it to have evidentiary value, it's really best that it be done by somebody who has specific training in forensics. A good defense attorney, aside from the fact that if you complete the form, you need to be willing to testify in court about it. Good defense attorneys love to rip people apart if they complete these without specialized training. We can talk about how true that is, but I just wanted to put it out there. If we are doing a forensic exam, ideally you want to give the person the option to choose the gender of their provider, or at least to have somebody of their preferred gender in the room, if possible. This isn't always possible. Often, particularly at public facilities, there's only going to be one qualified doctor available. So you might have to have a nurse or a social worker accompany into the room. If the person would like to have somebody in the room, that is something that can be discussed. It isn't routinely done, but should be, that a person should be offered analgesic if they're in pain. Public services will not have anxiolytics available to offer the person to help them get through this. You might be able to talk about that in private facilities. The most important thing, if there is going to be a process of a forensic exam and a J88, is to ensure ongoing consent. And this is something where there are, unfortunately, some public facilities that have some issues. There is a special consent form to sign if they're opening up a rape kit and you're going for one of these exams. And I have had providers say to me when we're doing these processes, and I'm sort of probing about how do you maintain ongoing consent, I have had people just say to me, they signed the form, we've opened this very expensive kit, we're finishing the kit. Obviously, that should not happen, but it's important to be aware that it can happen. If you are in a role of supporting a patient through this process, obviously there can be some discussion about how to ensure ongoing consent. And to remember as a provider that any patient can withdraw their consent for any medical procedure at any point, and allow them a tap out or a safety signal. Particularly with TGD, it is very important with all sexual assault survivors, but in particular with TGD patients, I think, to explain all parts of this exam before proceeding. Why do we need to, do a detailed examination of the outside of your body? If we're going to be doing a genital exam or an oral cavity exam or an anal exam, why are we doing it? What are we looking for? What are these swabs for? Explain everything before you do it. And pay particular attention to giving people privacy for changing, draping, be very aware of the likely gender dysphoria, talk to the patient about how they want to talk about their body parts, and use the patient's language to describe their body while you're interacting with the patient. The J88 needs to use medical language. In air quotes, because obviously there are certain kinds of privileging of language, but explain to them why the form is going to be written this way and how that has the potential to help them later on if a prosecution is going forward. The other important point to note here is we begin by medically stabilizing the patient. Then we do the forensic exam, and then we treat minor injuries, and then we do the HIV testing, and so on and so forth. The reason that we do that is because if there is any physical evidence, for example, in the anus, in the oral cavity, in the vagina, that can be retrieved by a swab, you want your first swab and your first examination to be collecting that forensic evidence. If you've done other kinds of procedures or swabs beforehand, you're going to compromise the evidence. The same with the patient's clothing, the same with bathing. Ideally, if you want to get the best possible evidence from one of these exams, the patient should not change clothes, they should not bathe, and in a perfect world, they probably wouldn't urinate, but I think that one is a particularly unreasonable ask given the discomfort and the likely return. If the patient really needs to change clothes before going for the exam, the clothes should go into a paper bag, not plastic, to preserve the evidence. So that's your forensic exam. It's a sort of big and dramatic piece of this, but it's not actually normally your patient's biggest need. So what do your patients then need? So following an acute incident of sexual violence, and sometimes a case of intimate partner violence, it is important to assess some medical health risks and provide appropriate prophylaxis. This is a point where I do take issue with some of the sort of standard operating procedures that can evaluate facilities on whether they have given everybody who has walked in the door the full suite of pills and shots. And that view providing comprehensive post-violence care as providing pills and shots. The pills and the shots can be important. I'm not going to suggest that they aren't. I am going to suggest that particularly with people whose bodies can be overly pathologized and who might have a very complicated relationship with medical services, but honestly with anybody who's just had an experience in which their physical autonomy was violated, it's really important to actually talk through the medical history and the history of the event and not give them anything that they don't actually need. And when I'm talking about taking a history here, you need to establish what anatomy is present in your patient, regardless of their gender identity. And what actually happened during this assault. And in particular, was there penetration? What anatomical site on the patient was penetrated? Was it a mouth, an anus, a vagina, and obviously you would call that by whatever the patient wishes to call it, whether it's their front hole or their bonus hole, or they're happy calling it a vagina. If there was penetration, by what was their penetration? Because obviously you're going to have very different risks if it was an object, a finger, or a tongue versus a penis. This may feel like a lot of detail to have to get into, but it is important so that you're not just throwing completely unnecessary and difficult to take medication at somebody. Now, obviously in South Africa, the first thing that we're concerned about is HIV. And if there has been a penetrative assault by a penis, it is particularly important to think about post-exposure prophylaxis. This is not something that should be forced on a patient, but one definitely needs to go through it. I'm trusting most people are relatively familiar with the protocol for this, but just to review, if the patient is known positive, obviously you don't do this. They're already HIV positive, and if you have a record and know that the patient is already on antiretrovirals, we're going to skip this step. If they are not known positive, you want to offer HIV rapid counseling and testing. Now, it is allowable to give a patient PEP if they decline the HIV test, but you need to explain to them the risks of taking PEP if they're already HIV positive in terms of compromising their future treatment and health outcomes. So you do the rapid test. If they're negative, you're then going to offer them a 30-day course of post-exposure prophylaxis with an antiemetic. And if they happen to be positive, you're going to be especially careful in talking to them about this, because this is a really terrible moment to find out that you were already HIV infected. And you will refer, and ideally you will do a warm referral where you actually physically take the patient to their next provider, or you make the phone call on their behalf. But you are not going to ideally drop a patient with an HIV positive test result that they weren't expecting in the moment when they've just been sexually assaulted. You will then want to ensure follow-up testing no later than 3 months, no earlier than 6 weeks, to make sure they haven't seroconverted. And at that point, you'll want to have a conversation with them about PrEP, and I will explain why that's super important in a minute. If you've had a penetration, you'll want to consider offering presumptive antibiotics. You will probably, because Hep B is so easy to transmit in this kind of event, ideally you will do a hepatitis B antibody titer first, but you will probably want to give them a Hep B vaccine. Tetanus, again, this is a thing that can make somebody feel really miserable, and it tends to be given routinely, at least in public facilities. I think it's really useful to look at, were there skin punctures? Are there open wounds? Did they have a recent vaccine? And do a little bit of risk-benefit analysis before you add in yet another thing that's likely to be painful and miserable for the patient. Now, if your patient has a uterus, the default tends to be to throw emergency contraception at them. Obviously, if you have a trans or gender diverse patient with a uterus, and particularly if that patient is receiving any kind of gender affirming care or hormone replacement therapy, you'll want to have a proper conversation with them about the likelihood of pregnancy risk, whether they're using anything else to prevent pregnancy. And I don't know if we have any endocrinologists on the call who can then talk about the effectiveness of the large dose hormones that are used for emergency contraception if somebody is on testosterone. That's a personal question that I have. So if we have an endocrinologist who can answer it, I'd love that. But if you had penile vaginal penetration and the patient has a uterus, and you've talked with them about the risk of pregnancy and they're not currently pregnant, again, you do a pregnancy test. And if they're not pregnant, you can offer them emergency contraception. If it's within 72 hours of the unprotected exposure, you can offer oral emergency contraception. And this is something you don't even have to be having a major medical encounter with a patient to explain to them that this is an option. Oral emergency contraception is available over the counter in South Africa. A patient can go and ask at any pharmacist, and at least all of the major pharmacies should be willing and able to dispense this. Another option to consider that's less often offered, but you can get it from gynecologists or from a place like Marie Stopes. The TCCs don't do it, is that you can place an emergency intrauterine device, and that can, depending, easily go out to 5 or 7 days post-assault, and then obviously that provides ongoing protection against pregnancy. You can't do it with a Mirena, but just about any other IUD will work for that. What you need to do if you are giving any of these interventions, and in particular, if you're starting a patient on post-exposure prophylaxis or giving emergency contraception, is get the patient some food and some water, because these medicines are really, really miserable to take. And this is something where we have occasionally seen problems with public sector facilities. We had one facility tell us, oh, you know, SAPS doesn't want to give our patients safe rides home because of the medication we give them. They tend to vomit it up in the back of the car. And so we've really been saying, no, but you have to then feed the patient. If you're giving a patient medicine that's supposed to be taken with food and you're not giving the patient food, and you're getting a lot of complaints that the patients are then vomiting the medication back up, you haven't actually given the patient medication. Fortunately, we've had a really receptive audience for that one, and a lot of facilities making a plan to ensure that patients can take their medicine. But if you're supporting somebody through this process, these are some of the things to be a bit attentive to. So we're going to do a slight diversion here and talk about why ongoing counseling following a sexual assault is important, but also why you want to consider offering pre-exposure prophylaxis if somebody hasn't seroconverted from the rape. And this was the rape incident cohort evaluation study that some colleagues of mine at MRC did with a bunch of the TCCs in KwaZulu-Natal, comparing a cohort of women who had recently been raped and presented to TCCs to a cohort of women who presented at public facilities for routine care and following them forward in time. And what you see is that women who have, now this is now cis heterosexual, well, we don't know the sexual orientation of the women. This is cis women who have experienced penile vaginal rape, but they all sought services, which many women do not. They all received services, were all offered post-exposure prophylaxis, most of them took it, but they still had a 60% increased likelihood of seroconverting over a 1 to 2 year horizon than women who had not been raped. Now, obviously, that's not resulting from the rape itself. If you're going to have someone seroconverting from an assault incident, you're going to pick that up normally within 6 weeks. So this was a long-term increase in risk. And why is this happening? And this is a bit of a complicated diagram, but really what we want to emphasize here is that the trauma of a sexual assault has long-term mental health consequences and often long-term psychosocial consequences. So you've had the physical trauma, but also you then have an increase in anxiety, post-traumatic stress disorder, depression, that can result in self-medication, that can result in acting out and engaging in high-risk sexual behavior, that can result in neglect of self-care. All of those things can increase risk of HIV acquisition. And So this does appear to be why we see this increased risk of HIV acquisition for 2 years following a rape event, and why you both want to talk to your patient about PrEP, but in particular, why survivors need long-term psychosocial support and therapy. So with that little PSA handled, the big thing that you want to do once you've attended to these sort of immediate and time-sensitive medical needs, understanding that the HIV post-exposure prophylaxis and the emergency contraception and the collection of forensic evidence are time-sensitive, is you want to arrange for follow-up and referral. And if this has been an acute presentation, it is helpful to have a doctor explain, or a nurse explain to the person what to watch for if they've had a closed head injuries or if they have been strangled, because you can get emergent symptoms of a concussion, and you can, for sort of, I'm not great with the strangulation thing. I've had the late emerging concussion problem myself. But with the closed head injury, if you get a headache, dizziness, blurry vision, or interestingly, incredibly labile affect, that can be a sign of an emergent concussion. Can also, if somebody has had a closed head injury, result in them presenting for care with labile affect beyond what you would expect. And so if you have a patient whose behavior is extremely erratic, that might be a good sign that they actually need a scan, not that their psychiatric health is seriously compromised. Strangulation, you can get swelling around the esophagus up to 48 hours afterwards, or and around the trachea. I do know my anatomy, I promise, even when I'm not necessarily using the words correctly. So if they start coughing or wheezing or having extreme difficulty breathing, they also want to come back for care. You need to explain if there's a need to retest for HIV and or pregnancy and or STIs, and talk about that. The most important thing, although not all patients will take you up on it, is to try and arrange some ongoing counseling and trauma debriefing for the patient, and then to arrange for them as necessary transport, emergency housing, legal services that can support them with protection order, and etc. You need to talk to the patient about whether or not they can cope with, and it will be helpful or safe for them to have written discharge instructions. Depending on who the perpetrator was and depending on their circumstances, they may not want to take written discharge instructions, and it may not be safe for them to have them. And then obviously, if the patient isn't literate, that won't work either. But you should just assume that if you've seen a freshly traumatized patient, they're not going to remember anything that you told them. And this is not an issue of them being defiant or non-compliant or anything other than, if you're dealing with a freshly traumatized person, they're not going to retain stuff. So if at all possible, you or your service should really arrange to call them to follow up and to check on them and to be sure that they're aware of their follow-up appointments, and actually just take that cognitive burden off of them to get this immediate aftermath handled. So let's me look at some people who are looking very serious at me, and assume that the rest of you are with me. Sakile, can I ask if any questions pop up in the chat that you just, that seem urgent, you stop and let me know, or if people start waving their hands, I want to say, Kale, what the hell? I'm assuming that you're saying something agreed. Yeah. Okay.
Yeah, sure. We'll do. We normally take questions and discussions towards the end of our presentation.
Okay. I am going to start skipping over stuff because we sort of started late and that took long. But when we said that the balance of providers were psychologists, I feel like psychologists probably know a lot, and psychiatrists, I hope, know a lot about how to handle trauma and might not necessarily know the medical things. And it's, I think, important to be familiar with them so you can help a patient with expectations or understanding what your patient has confronted. So we should, however, recognize the role of trauma. I'm going to trust that everybody who works with TGD patients is used to dealing with traumatized populations. Let's talk about some of the essentials for handling intimate partner violence and other historic or ongoing sexual and gender-based violence. We've talked a lot about post-GBV care and the range of things that happen there. I want to pause and talk a little bit about WHO and CDC recommendation for first-line support. And first-line support would be any medical or clinical encounter where you are hearing about violence from your patient, and that can be whether you're doing HCT or offering any other service. And what do you then want to do to help contain the patient, avoid causing any additional harm to the patient, and make sure that the patient or your client has what they need going forward? So the acronym that WHO and CDC use for this to describe what you want to do in a sort of first-line clinical encounter when you're receiving one of these disclosures is called LIVES, which stands for listen, inquire, validate, enhance safety, and then offer support through referrals. So I hope that all of us understand how to listen closely with empathy, without judgment, with keeping our own stuff and our own histories contained within ourselves for clinical supervision or friends or whatever kind of support we get. And having listened and heard what's going on for your client, you then want to assess and respond to the client's needs and concerns, looking at emotional, physical, social, and practical. And I want to talk about some structured resources for starting to look at them. You really want to offer your client validation, tell them that you believe them, offer some empathetic reflection, offer your support and encouragement for the fact that they're still alive, that they've gotten this far, that they honored you with their trust and telling you what's going on. And definitely, obviously, don't say anything victim blaming or critical, et cetera, et cetera, et cetera. We then want to talk about enhancing safety. And this is where, since I want to leave some time for discussion, I want to focus most of the rest of the conversation right now, and then make sure that they have supportive referrals for services that you can't necessarily offer them. So why does my computer not advance the slides when I want it to? So why is it important to sort of keep this set of steps in mind? So if a client discloses to you, and it's highly likely that this is the first time they've disclosed, this is sort of your moment. And if you re-traumatize them, or if they have a bad moment in having this conversation, they're less likely to seek help in the future. And this can really affect their access to future services, in addition to just being damaging in the moment. So I am now going to see if this is going to let me skip ahead a little. I don't really want to. All right, I might just jump around. I'm going to trust that all of you know how to enhance privacy. But definitely, if you're talking to somebody about violence, nobody older than the age of 2 should be overhearing on your conversation. So why do we talk about enhancing the client's safety and ensuring their safety? Well, we obviously can't ensure their safety, but we do want to help them think through in a structured way what kinds of risks they're facing and what are some contingency plans that they could put in place. We also, particularly in a situation of intimate partner violence, do not want to jump straight to telling the person to leave their partner. The person may have a wide range of other priorities, and we as providers also need to be aware and to ensure that the patient is aware that the moment that you're leaving an abusive situation is the most dangerous moment for an escalation in violence and an escalation in lethality risk. And so if somebody is going to leave their partner, that is a moment to really think through how to do it safely, how to ensure that there are safety plans in place, and how to make sure that the client or the patient knows to expect the possibility of an extinction burst of extremely over the top, manipulative, or violent behavior, and to be prepared to recognize that for what it is. So we don't want to jump straight to telling the provider to leave, or to going straight for a safety plan that relies on getting the person out of their home. This is an option that you can explore with somebody, but you want a plan that is tailored to the person's priorities, particularly if there are children in the household. But it should always be based on balancing risks, particularly for a queer person who might be at risk of being outed in particular ways. You probably can't make sure that the person is going to be safe, but you can engage in harm reduction and you can enhance their safety, right? So we can't eliminate the risk of violence, particularly in South Africa, but you can help your client be prepared for and reduce their risk to put appropriate contingencies in place. And if they do want to exit in a way most likely to result in sustainable outcomes. So, for example, it's important to be aware of the patterns of abuse. Abuse, many people will be familiar with the cycle of violence, where you have a violent incident, and then the abuser will become incredibly apologetic and incredibly loving. This both serves to hook the person back into the relationship, and it can be serving to assuage the person's own guilt. We can talk about this. But classic cycle of violence. You have a violent incident, you have lots and lots of apologies, affections, gifts, promises to never do it again. You then have escalating tension. You then have another violent incident, and around and around and around we go. This is where you may sometimes see behavior that looks paradoxical, where someone has intuitively, if not explicitly, recognized that this cycle exists and goes ahead and engages in behavior that looks like it's provoking or triggering a violent outburst, but really that person is just interested in getting the whole thing over with because they know it's inevitable. If a person is in the middle of that cycle and hasn't recognized it, it can be really important and empowering to name it. And it can also be really important and empowering to help the person recognize what are the signs that a violent incident is likely coming. So what can they then do to try and either get themselves or the children out of the situation? Can they make a plan ahead of time? You often want to coach the person, and I will give you some written resources for how to do this safety planning, about having a grab and go bag, all of this kinds of stuff. They want to figure out where there are safer places either in their home or external to their home, get away from weapons. So this can include things like go to a safer place, stay away from knives. If there's a gun in the house, we're going to have a whole different conversation about not staying in the house with the abuser and the gun if possible. Don't wear scarves or other things around your neck that could be used to strangle you. Maybe go away from the children. A range of other strategies that are horrible to have to talk about. And then talk about some basic defense strategies for protecting vital organs and so on and so forth. These things are difficult to have to talk about, but they're important. Other things that you'll want to help people work through longer term are making sure that they have copies of all critical identity and financial documentation and children's birth certificates, maybe stowing them off site, maybe stowing them with a person, stowing a grab and go bag, knowing who they're going to how they're going to get there, who are they going to call, thinking about financial contingencies. These kinds of things can be very particular, but thinking through not just the immediate details of safety, but all the aspects of life and all of the things that a person needs in order to be safe, and gaming out all of the contingencies, as well as gaming out what it will mean to get through an extinction burst of violence. The other thing that's important to think about, and I will provide you also with some tools for doing this, is to think about the lethality risk of the situation. We all know that intimate partner femicide is a big problem in this country. While there are a lot of rape femicides, it remains the case in South Africa that most cis-het women who are killed by male intimate partners. We have no idea what the prevalence of intimate partner homicide, femicide, or murder is in queer relationships in this country. We're hoping that some of the work that's in the field now might help us get some answers. But the red flags for lethality risk are pretty much the same across the board. So if a client tells you that they think their partner is going to kill them, please take that very seriously. The client is probably in a really good position to know. If the partner has ever threatened to or tried to kill the client, that is a major red flag. If there's been escalating violence in the past 6 months, if the partner has ever tried to strangle the client, that can be fairly well construed as an attempted murder. If the partner or the household has involvement or access to potentially lethal weapons, understanding that most weapons can be lethal in the right hands, and particularly if there is a gun in the household, those are all major risks for an escalation to lethal violence. And if the client or your patient is somebody who can become pregnant, violence in pregnancy is also a major risk factor. So in this case, you are still going to respect the client's autonomy. You are still going to respect the client's priority. But it is a moment that you can really share with the client how concerned you are for their personal safety, and really try to invite them into a process of planning for their own personal safety, assuring them, of course, that they will have your continued and ongoing support regardless of what happens, and that what they experience is not their fault. So your final step then is to support your client through referrals to services that you cannot offer. I again want to encourage people who have experienced a lot of violence, can be really overwhelmed. It really can compromise executive function. To the extent that you can do warm referrals, make calls for them, help them make their appointments. That really is something that's beneficial in this case. You do want to make sure that you have a system for referrals in place. If you're going to be talking to your clients about violence, and you probably are because this is South Africa, and we're working with a highly vulnerable population that's very likely to experience a wide range of kinds of violence, then you need to know what services you can offer and where else you can send the client that they are going to get TGD friendly and appropriate services. Have a slide here on warm/active referral, but this is really a good way to reduce barriers to services, offering them space in your office to make the call, making the call for them, making the call while they're there. Make sure when you're making referrals that you know who you're referring to, whether or not they're competent in working with TGD patients, whether or not the service is still available. Services in this sector, as we all know, can come and go. And really think about the range of services that people might need. I'm just going to skip ahead a little because I do want to leave time for conversation more than just me talking into a computer screen. But just to reiterate, if you are using this WHO and CDC recommended approach for handling these disclosures, you want to ensure respective, sensitive communication with your clients. Recognize that the client is the expert, but you want to explore their options and respect their wishes and their priorities and their value. You want to be non-blaming and non-stigmatizing. You want to recognize that the client has had their power and their agency and their control taken away from them, and to be particularly careful in your interactions with the client that you are restoring those. So let's just, before we switch over, talk about, these are sort of pasted whole cloth from a WHO handbook, so they are a bit cishet in focus, but the content is correct. So you're responsible for understanding the dynamics of sexual and gender-based violence and intimate partner violence, and for prioritizing the client's safety and the client's agency. You're responsible for creating a safe environment. You're responsible for understanding how gender power differences and cis-heterosexism and queerphobia and transphobia impact access to resources and interactions with the health system, and using your relative position of power to help buffer the client against some of the worst of those systematic abuses and help them navigate the system. You're responsible for reinforcing the value of your client through how you interact with them, and for respecting their dignity and giving them autonomy and letting them drive decision-making processes. You are not responsible for solving it, for keeping them safe. You cannot do that. That's not your responsibility, and that's not within your power. As healthcare providers, you are not responsible for determining who's at fault, the legalities, determining, particularly in queer relationships, we can get into all kinds of stuff about, is it mutual, is it this? It's not your job when you have a single client in front of you to sort that out. It is not your job to mediate the couple's relationship. It is never your job to force anyone to make any choice, even if it seems obvious. And you don't have to know all the answer. You're responsible for consulting with your colleagues and being humble about the limits of your own knowledge. I wanted to offer a couple of resources, and in particular, this first one, myplanapp.org. This is available for Android and iPhone. It has so this is an app, it's also a website that will walk a third party, which can be you as a provider or your client, through all of the things they need to think about to evaluate red flags, green flags in their relationships, look at the levels of power and control they might be experiencing. And if they want to make a safety plan, it helps them go through a process of values clarification and think about safety planning and self-care. The user interface on the app is a little clunky, and lot of the resources it points to will be US focused, which isn't great. What is nice about this app is that it is very queer and trans inclusive. And when you are setting up a scenario to game out safety planning, it will prompt you for your own gender and does allow for non-binary genders. It will prompt you for the partner's gender. It will ask you what pronouns and English it should use to refer to the partner in the situation. And when it's thinking about things like evaluating pregnancy risk, it just wants to know if you have a uterus and what's going on. It was originally developed, and I mean, it's very data-driven and largely based on global research on lethality risk for cis women who partner with men. There are some versions of this work that are specific to trans women that aren't sort of as fully developed or in the field yet. But even though we don't necessarily want to use a very American focused resource, I have been through it. It's not bad for South Africa. And for this population, the fact that it is queer and trans inclusive, and for as much as lesbians aren't always trans supportive, I happen to know the lesbian who led the development of this app. She's a leader at Johns Hopkins School of Nursing, and her trans politics are perfectly on point. So these other resources are also American. If people have some South Africa specific resources that you can put forward, I want to leave us some time to talk about all of that. And I hope I have now left us a reasonable amount of time to at least have a little bit of discussion, and that information was at least a little useful to people. Over to you, Mr. Chair, Dr. Chair, sir.
Thank you so much, Ka, for such a thought-provoking conversation. And like you did say, like you premised it in the beginning, that for all of us that are working in the South African context, violence is a reality, and it's a reality certainly for our trans and gender diverse clients. So for me at least, this was very informative, and it's nice. I imagine that for people that haven't necessarily worked at the rape crisis centers, it's nice to know what our clients face. It's just soon after they've been traumatized by the violence that they've experienced.